We're delighted to have Mark Sculpher here from the University of York. He is a professor and also the director of their Health Technology Assessment Program. For those of you who know, who aren't aware of how England does cost effectiveness, they're about 10 to 15 years ahead of the US in incorporating cost effectiveness evaluations systematically into the implementation process. And we're delighted to learn from that experience. Mark has not only been working in cost effectiveness for now more than 2 decades, but also has contributed greatly to the methodology that we use and continues to contribute to the methodology that we use in this field. He's written several textbooks where we heard from Doug earlier about the second panel on cost effectiveness that is due to publish later this year. So that is a revision of the gold textbook, which, no pun intended, is the gold standard in our work, and has been for 2 decades, and I'm thrilled to see how that turns out. He's also worked with the Gates Foundation more recently, and we're excited to hear about some of his experiences on that front. So without further ado, Mark, thank you for joining us.
It really is a great pleasure to be here. I'm so glad to have been invited. Not only do I get an opportunity to talk about what I think, and I hope some of you think are interesting topics to great people, but I get away from the English winter. I get to drink some California wine. It's absolutely perfect. Of course, I had the difficulty about choice of whether I should wear a tie or not. Whenever I go to the East Coast, everybody wears a tie, and I always felt underdressed. Of course, I should have known the West Coast is a bit different, a little bit more relaxed. But anyway, of course, I was asked to provide a title for this talk a while ago, and this was the title I came up with. And of course, coming up with a title before you actually done the content is not always the best thing to do. So there's a slightly different title in reality now, which is Learning Lessons from the NICE Experiment. When I was first in this field back in the 80s, it was the Oregon experiment, which was really interesting to budding health economists. And I think the NICE use of cost-effectiveness analysis has been something of an experiment and has revealed some very interesting things. It's been a mixed story. There have been times when we can get really rather depressed by it, about how we seem to have gone backwards over the last 5 years. But when you look at the big picture over the last 15 years, I think ultimately it's been successful. So just some acknowledgements to start with. This is work reflecting a whole lot of research over several years, and here are some key collaborators with whom I've worked. And also we at York are funded reasonably lavishly, actually, by our National Institute for Health Research to do technology assessments to guide NICE's decisions. So there is a financial link there. Now, what I'm going to talk about actually follows on very, very nicely from that panel session. I couldn't have planned that panel session better if I was doing it myself, in terms of the key issues that were coming up and how they relate to some of the challenges we've faced in doing cost-effectiveness analysis for NICE. What I'm going to talk about, I'm going to put my glasses on first, actually, I think that'd be easier. What I'm going to talk about is really the reflections on how well cost-effectiveness analysis has gone with NICE. And in particular, I'm going to talk about 2 really challenging areas that we've faced. And they've come up already today. And that is defining a cost-effectiveness threshold that is meaningful and is relevant to the decisions of NICE. And then secondly, how we might reflect multiple criteria, other than just health gain, QALYs, in decisions, and also multiple perspectives, that is, costs that fall outside of the NHS budget. And I'm going to finish off with some thoughts about outside of the UK, and in particular, some reflections on how this experience with NICE has contributed, has impacted on my contribution to the panel that Doug mentioned earlier, and some of the debates we've had there, but also the work that I've been involved with and colleagues at York through the International Decision Support Initiative, which Elliot mentioned earlier, which has been funded by NICE. So let's start off with something quite general about NICE, which stands for the National Institute for Health and Care Excellence. They've kept the same acronym, but had different names over the years. It started as the National Institute for Clinical Excellence, then went to the National Institute for Health and Clinical Excellence, and now is the National Institute for Health and Care Excellence. And it relates in part, those changes in name, to the growing remit of NICE, as I'll come to in a minute. It was introduced in 1999, and what I'm going to focus on is technology appraisal. That is, NICE's role in issuing guidance to the NHS about the funding of mainly new branded prescription pharmaceuticals. There are some devices, medical devices in that, and surgical procedures. One of the early appraisals was a prophylactic removal of wisdom teeth. So they do get some oddities in there, but it's primarily branded prescription pharmaceuticals. Back in 1999, they also covered clinical guidelines, which they still do, but now they have a whole lot more under their remit. And ultimately, its role was to take the politically challenging decisions about funding, rationing, away from the political front line. I frankly doubt it's done that, and it's still highly politicized. But that was the original motive. And the science, good science and best evidence has been at the forefront of NICE's activities over that period. Again, it's sometimes come into conflict with the politics, to be quite honest, and I'm very happy to talk about some of the realities of that, perhaps with a glass of wine later, but it's been one of the major challenges. An important thing to recognise about the technology appraisal programme, the drug programme if you like, is that there is a financial mandate. So if NICE says this is cost effective and it's effective and it should be used, the NHS has to find the money for it. And not only that, as I'll come to in a minute, the NHS has to find the breathing space. In other words, they have to find the things they're going to get rid of to fund these new interventions, which, of course, 99.9% of the time cost more than current practice for that given patient group. And NICE has had something of an international impact. I guess in this room we might be interested in the scientific impact of NICE and its use of cost-effectiveness analysis, but it's had a big impact on pharma. So given that we're only 3% of the world market for branded pharmaceuticals, the impact on the pharmaceutical industry, or their perceived impact, is much larger, in part because NICE has sort of shaped somewhat how other countries have thought about making these decisions and how they use evidence, but also because of external reference pricing and the fact that 25% of the world market references the price of new branded pharmaceuticals in the UK. And the whole issue of price discounting and hidden price discounting as a way of showing cost effectiveness has been a major feature of the last sort of 10 years of NICE. And the fact they have to remain secret and hidden because otherwise they're referenced for that other 25% of the world market. So that NICE has had this international resonance for a number of reasons. So what this chart shows is NICE's guidance since 2000 up to 14-15, and the different colours, I know it's probably a bit difficult to see, show the different activities of NICE. What I'm going to focus on is technology appraisals. That's the sort of high-profile area of NICE's activity, drug decision-making. But you can see, actually, it's a relatively small proportion of what NICE does, because NICE has a number of other programs, including public health, medical devices, diagnostics. I'm currently on the diagnostics committee, for example. Social care most recently, hence the name National Institute for Health and Care Excellence. And there's a hell of a lot going on. It's a big organisation, which interestingly has recently had to somehow find 40% cuts, internal cuts in its staffing, despite taking on more activities. So it's a challenging organisation to work in, to be quite honest, currently. And here is just a list across across disease areas up until I think about 2013, showing that just the distribution of drug appraisals or technology appraisals, they're mainly drugs. And you can see how cancer, and particularly cancer drugs, I guess they're all drugs, have dominated in this area. And the politics of the funding of cancer drugs and its relationship to cost-effectiveness analysis is one of the sort of enduring stories with NICE. Indeed, just an hour before I left for the airport yesterday, we had the chief executive of Pfizer on our national television, national radio, talking about just how badly NICE evaluates value compared to the French and the Germans and the Swiss. Didn't mention the Americans, I have to say. And you know, not explaining exactly why that was and how he should do it differently. But yeah, the whole cancer drug story is one we could talk about for a separate session. But the other thing that NICE has done, NICE did very clearly back in 2013, this was updated in 13, it was back in 2004 actually, this originated, was to define relatively clearly its preferred methods of cost-effectiveness analysis. It called it a reference case, which of course follows the Gold Book that Doug referred to earlier. The concept of the reference case has been very influential, I think, internationally. And this is the reference case. Key things to note, firstly, a perspective on outcomes. NICE is very much focused on health outcomes. So, as I'll come to in a bit, you know, other types of consequence that may be relevant, may be thought relevant to decisions, and the public might think relevant to decisions, has been hard to include. Secondly, measurement and valuation of health. NICE is very clear, unlike I think any other HTA agency in Australia, Canada, elsewhere in the world, that the QALY is its preferred measure of health for cost-effectiveness analysis. That's not to say that it doesn't get into the minutiae of the clinical evidence as well in assessing the clinical effectiveness of new technologies, but when it comes to cost-effectiveness, the QALY is king, according to NICE. And more than that, the way we measure health, what you might call utilities, we try and avoid that term. We say it's a measure of health-related quality of life. The preferred measure at NICE is the EQ5D, which, when you come to the US, is always something I think people find difficult to understand. And the idea of sort of direct utility elicitation, which I know is still something that's used a lot in the US, very rarely happens in the UK. And then finally, perspective on costs is that of the NHS. And PSS means Personal Social Services. It's basically the NHS budget. That is the focus. So NICE's role is to figure out which new interventions are cost effective in terms of improving health, population health, subject to the NHS budget constraint. Now, that is the sort of methods framework that's been in place since 2004, but effectively since the advent of NICE in 1999. But it's been challenged in a number of different ways, and those challenges really are all about how the realities of decision making inevitably involve a whole host of considerations. But NICE has been very clear, and it's legally has to consider the cost-effective use of NHS resources. And how you bring those things together appropriately has been challenging for NICE and challenging for those academics working with and for NICE, but has also been very interesting, and I think has provides a lot of insight as we think about how cost-effectiveness analysis could be used elsewhere, including in low and middle income countries, but also the limits to cost-effectiveness analysis. And I guess I claim much less than I did 15 years ago about what cost-effectiveness analysis can do. But equally, I expect every decision maker that is working in a system, certainly like the NHS, but probably I would suggest every system, to think about economic principles. So whether we call it cost-benefit, cost-effectiveness analysis, I think we can get into tangles over those types of discussions. Ultimately, It's about, what is this measure of benefit we want to maximize from our available resources? How do we estimate it? And how, crucially, do we estimate the opportunity cost, the things we don't do when we invest in particular new activities? So I'm going to talk about, in particular, the cost effectiveness threshold challenge and the multiple criteria and multiple perspectives challenge. I originally also planned to talk something about uncertainty and evidential uncertainty, which is a major issue at the moment in the UK, as regulators now are going for conditional licensing, adaptive pathways, which essentially means that drugs are getting marketing authorization with much less evidence than they did in the past, and that's causing huge issues for funding organizations. How we deal with that analytically is an interesting area. And I was also going to talk a little bit about incentivizing, dynamic efficiency as it's called, how we incentivize pharma and other life science manufacturers to produce cost-effective, evidence-based technologies. However, I haven't got the time to do all four of those, so I'm going to focus on the first two, but I'm happy to talk later and informally at breaks and after. So let's talk firstly about the cost-effectiveness threshold. We've talked already a fair amount about it today, and so some of the issues will be, I hope, familiar to you. NICE has always, well, pretty much always, I think, adhered to the view that the cost-effectiveness threshold is a supply-side concept. I think Elliot talked about demand and supply side. In other words, it doesn't believe that the cost-effectiveness threshold really represents something about an aspiration for how much money the NHS should have, could have, wish it had. It's very much a supply-side concept. That is, we have a fixed budget, and the question is, how do we spend that most effectively? And so this is NICE's methods guide. They talk about a fixed budget constraint, and therefore the maximum acceptable ISA has to be considered alongside the opportunity cost of programs, existing interventions, programs, treatments that are displaced when new, more expensive technologies are let in. So it's very clear about that. But it also recognises it doesn't have a complete league table. We talked about league tables earlier. It doesn't have that, nor does any health system in the world. A list of the cost effectiveness of everything it does, the millions of activities, the different patients and subgroups of patients in the system. So its way around that has been that it generates a sort of range of maximum acceptable ISAs. It's a threshold range. Which currently is 20 to 30,000 UK pounds per QALY. So that's been its position. And so the way that works analytically is that, so for those who do CEA in the room, you'll understand this readily, but I hope this is helpful for non-specialists as well. What we've got here is, we're thinking about let's say a new drug, and we're looking at the additional cost. So the y-axis here represents the additional cost of that new intervention compared to standard practice, compared to the usual care for the particular patient group we're talking about. So this green blob here at the origin is existing practice. It's costs and benefits. So the costs and benefits are all relative to the origin, which is usual practice. And then on the x-axis, we've got the health improvement offered by that new intervention relative to usual practice. And here we're using QALYs, we could use DALYs averted, but importantly, we do need to measure health in generic units. We do need to measure it in a way that we can compare across clinical areas for reasons I hope that will become clear in a minute. And so we might think about a new technology at a particular price, P1, and at that price, that technology will impose £20,000 worth of additional costs on the system per patient. So that's over and above. That's not just the acquisition cost of the drug. It's the full cost implications, net cost implications of that intervention per patient. £20,000 more than usual care, but it generates 2 additional QALYs per patient compared to usual care. So the usual thing to do, well, we'll divide 20 by 2. Our ISA's £10,000 per QALY. We have to judge them. Is that worth paying? Well, a supply-side threshold, cost-effectiveness threshold of say £20,000, what that tells us is the extent to which a given additional cost displaces other patients' health. So at £20,000 per QALY, that will be represented in the gradient of this line through the origin, £20,000 additional cost from this new drug will displace one additional QALY, one QALY from other things. So this could be a new drug for metastatic breast cancer. What gets displaced in a system like the UK, but I would argue in many other systems as well, could come from a whole host of different areas. Could come from pediatrics, general surgery, cardiology. But what this threshold tells us is with 20,000 additional costs imposed on the budget, one QALY per patient is going to get displaced by other patients elsewhere in the system. But this drug, at this price, is cost effective, i.e. the ICE is below the threshold, but more importantly, it's cost effective because we get 2 QALYs per patient from the new technology, and we only lose one, forego one, through other treatments that are displaced, and therefore we have a net health benefit of 1 quality adjusted life year. Now, the reason, just slightly in passing, I think that's a much more intuitive way of thinking about cost effectiveness analysis. The way I teach this to clinical medical students is this is just extending the concept of harm, right? They're used to thinking about the benefits of treatments, the harms of treatments in terms of toxicity side effects. This is just another dimension of harm. If this treatment costs more than standard practice, we're going to have to find savings in our budget. We have to do less of other things. Doing less of other things will have detrimental health effects on other patients. That's another dimension of harm. And that's all we're representing here, the net health benefit associated with that technology. If this price was higher, we're now incurring a cost of £40,000 per patient. The ISA is £20 per QALY. What that means is, well, at that price, we get exactly the same health gain from the new technology, 2 QALYs, as we forego for other patients in the system as a result of displaced services to fund the new technology. So at that price, which has also been known as the value-based price, which I'll come back to later, that is the maximum price the system can afford before it starts incurring a net health loss in its population. That is the point at which the system is effectively ambivalent between the two options of whether to fund or not to fund. And then a higher price at P3, now an additional cost of £60,000 per patient over usual care. Now we have a cost per QALY of £30,000 per, an ISA of £30,000 per QALY. At that point, we're getting less health from the new technology than other patients give up through displaced services. The system will be, if agreeing to fund at that price, that will result in a net reduction in population health. So that is how NICE sees the world, at least in its methods guidelines. On paper, that's how it sees the world. But the problem is that £20,000 to £30,000 per QALY had no empirical basis whatsoever. And NICE was roundly criticised over many years regarding, well, where does this £20,000 to £30,000 come from? The industry always trying to push it up. The NHS are always trying to push it down. So the NICE, through a link they have with our Medical Research Council, were able to commission some research to try and provide an empirical basis for the cost effectiveness threshold in the NHS. And this was a grant we managed to get. And this is now published online, the Health Technology Assessment Series. You can find that online. And this has been a piece of work that's had some sort of major, it's generated some major ripples, shall we say, in the NHS and in government. It's, needless to say, highly controversial. I'll just talk you through briefly what this work did. So what we're essentially trying to estimate here is that opportunity cost. At the margin, if you impose an additional cost on the NHS budget, how much health will get foregone by trying to accommodate that cost? if you like, for the economist, it's the marginal productivity of the system. The margin, at the margin, how much does an additional sum of money generate in terms of improved health? Or conversely, if we take some money, a small amount of money away from the budget, what is the health decrement in terms of QALYs? And the way we sought to estimate this was to use NHS data on expenditure, which is categorised, so this is all NHS expenditure across the system, is categorised into 23 clinical categories, programme budgeting areas, 11 of which one might expect to associate with mortality gains or potential mortality impact. 11 of those 23 clinical areas you'd expect to impact on mortality as opposed to health-related quality of life. And so we looked at, we've also, at this point at least, back in about 2013, had 152 local health authorities, then called primary care trusts, and they were responsible for allocating resources in their locality. So what we were able to do is look at variation in expenditure in the 11 categories where you'd expect a mortality benefit, and to estimate the marginal impact of that expenditure on mortality. So what that gives us effectively is from small change in expenditure, the impact on mortality, and we can then link that to with some further evidence about the age and sex distribution across ICDs within these clinical areas. We can estimate the marginal impact on life years. So we can essentially estimate the marginal productivity of the NHS in terms of cost per life year. How much, if you gave them another £10 million to the system, what would be the marginal impact on life years? We can then build in the quality of life associated with additional life years. So through that NHS expenditure, you're impacting on mortality, but what is the quality of life associated with the additional survival duration related to that expenditure? And again, we're exploiting their information about the age and sex distribution and the quality of life associated with on average, with ICDs relating to these clinical areas. And then finally, and perhaps most challengingly, we have to recognise the fact that a whole lot of NHS expenditure doesn't impact on mortality, but in principle impacts on health-related quality of life, what we might call the pure impact on quality of life. And that required us to move away from just those 11 clinical areas with a mortality effect to all 23. And that involved assumptions about the impact on burden from the 11, the burden of health, the full burden, not just mortality, but also health-related quality of life, and to extrapolate from the 11 clinical areas where we had estimates on mortality and to assume the same proportional effect as they achieved on mortality to quality-adjusted life years for the other categories, the other 12 categories, which had no mortality effect. And so that altogether gives us the effect of the marginal change of expenditure in the system on quality-adjusted life years. Now, not surprisingly, there's a lot of uncertainty in that. There's a lot of necessary assumptions in that. Without going through all the detail, and that report I showed earlier is a fairly lengthy document, we estimated, our central estimate, that was that every approximately £13,000 additional cost that is imposed on the NHS budget through a NICE decision or any other decision, policy decision, would result in one quality-adjusted life year foregone. So that's telling us something about the marginal productivity. One side of government's been very happy with that. So the Department of Health took that straight to our finance department, reference our discussion earlier about going to finance ministries, and said, look what great value for money you're getting. It only costs you £13,000 at the margin to get one additional quality out of our system. Other parts of government, particularly that part working with the pharma industry, were very disappointed with this, because this is lower than our current threshold and much lower than where the industry have been arguing the threshold should be placed for a number of years. So it's been highly contentious. Now, one of the other things we could do with this work was to be much clearer with, well, in principle, with NICE as a decision-making body, or any organisation making a decision about the types of opportunity cost. So that tells us something about the number, the round number of opportunity cost. For every £13,000 imposed on the budget, one QALY will be foregone by other patients because of their services being displaced. But we can also say something about the clinical areas in which these opportunity costs fall and the type of health that's lost. So we can quantify so this is for a given, for £10 million worth of additional costs. So this could be a NICE decision to fund or recommend the funding of a particular drug that costs £10 million more than existing practice. How that additional, that 10 million gets funded, where it has to get taken from. You know, we don't know how these decisions are made, we just observe the decisions. So this is how they get distributed across the clinical specialties. This is the impact on effectively additional deaths or more premature deaths resulting from that reduction in expenditure in these clinical areas. This is how that gets distributed into life years lost, and you can see in red here some of the big clinical areas that would incur those costs. So interestingly, you know, cancer, all these expensive cancer drugs that NICE has struggled with, in making those recommendations, a fair chunk of the opportunity costs fall on cancer, other types of cancer patients from other types of treatments. We can show that in terms of total QALYs, and representing also the quality of life effects. So not just the QALYs representing mortality, but QALYs representing quality of life effects as well. So that, for example, is where mental health becomes particularly important, an area where we don't observe mortality impacts of changes in expenditure, but we very much do observe quality of life effects. So in a sense, this becomes a way of bringing alive to decision makers the hidden patient. So NICE is very, very proud, and rightly so, of the fact that it gets patients around the table. The committees all have patient representatives on there. What these patients tend to focus on are the interests of the recipients of the new treatments. What they don't talk about very often is those patients whose health deteriorates as a result of their services getting affected detrimentally to accommodate the cost of the new technologies. This is a way, we would argue, of bringing that alive. Now, that was in 2015. We can then ask the question, well, how does this, you know, if we believe the measure of opportunity cost that we've estimated, how does that compare with NICE's decisions? And indeed, how do NICE's decisions compare with its own threshold, £20,000 to £30,000 per QALY? Well, this was a piece of work done by Helen Dakin and colleagues, published a couple of years ago. And what they looked at was all NICE's decisions for branded pharmaceuticals, and they looked at the committee's preferred estimate of cost effectiveness. One of the real challenging areas in doing this research is that you don't always know. There's lots of ICERs throwing around. There's the company's ICERs, there's a whole lot of sensitivity analysis, then there's the committee's best judgment about what the right ICER is. And so they've tried to pick the latter in doing this work. Blue on this diagram, so each of these lines, if you like, represents lots and lots of different appraisals over time. The blue lines represent basically yes decisions, funding decisions, recommendations for the NHS to fund. The red lines represent no decisions, no recommendation to fund. And you can see that there is no deterministic relationship between NICE's preferred threshold, 20 to 30,000 UK pounds, and their decisions. And I guess you wouldn't expect that to be the case. You've got red down here, you know, potentially below 20,000, certainly below 30,000, you've got some reds. But you've also got some blues well above 20, well above 30. And the detail of this paper reveals actually that the threshold, or NICE's decisions, have been to recommend technologies at a higher cost effectiveness ratio over time. So they've been pushing up and up. And in part, that's because of a really important discovery, which is that the term threshold is used to mean all kinds of different things. Perhaps this is, we should have realized this years ago. The way we think about, and doing the work I've just described, have been thinking about the term threshold is as a measure of opportunity cost, the supply side concept we've been talking about today. When NICE think of the term threshold, they think, yeah, it's partly about opportunity cost, but it's partly about the value of things other than qualities that they want to reflect in decisions. So that gets us onto our second area, which is about multiple criteria. So the long and short of it is NICE has not reduced their threshold. It's still 20 to 30,000 pounds per quality. Interesting, our Department of Health have reduced their threshold to 15,000, but they've refused to tell anybody and put anything on paper about it, showing how political this is. So let me talk now about multiple criteria and perspectives, because these things, this and the threshold sort of come together in NICE's problems over the last few years. NICE has always been very clear that it takes other things into consideration. So this is again from its methods guide. This is the latest version, although they've been saying something similar for many years. So above the most plausible ISA of £20,000 per quali, they will take, to be cost effective, to be considered fundable, other considerations will be brought to bear. Firstly, the innovative nature of the technology. This has been a long-running debate between NICE and the government and the industry over many years. The extent to which, what innovation means, and the extent to which NICE should somehow be reflecting this thing called innovation over and above the health benefit offered by the technology. So the government wants it to take it into consideration. The question is how. This is sort of, in very general terms, how it does it. Secondly, NICE since 2008 has put additional weight on the benefits generated by technologies for patients with short life expectancies. So this came up, I think, earlier as well in discussion. If for patients who've got very short life expectancies, the qualities are given additional weight. Or, as NICE thinks of it, the threshold is increased. But really, it's about saying the qualities are of higher social value for patients with short life expectancy. It's another sort of tangent we could go off on. We can talk about it later. The empirical basis of that is very dubious. Again, it was a very political decision to do that. But it's one of the additional considerations that NICE uses in its deliberations. And then finally, although the reference case is all about benefits that relate to health gain, NICE is mindful of other non-health benefits. So, for example, effects on carers. Potentially, and we'll come to this in a minute, effects on time costs as well, as we've been discussing earlier. So basically, NICE has always tried to have multiple criteria in there. It's seen it, the way it's tried to do it is by fudging what this threshold is. It's not just opportunity cost. It reflects something about their value for these other things. But what it really, what everybody, both from industry and academia and government have said to them is you're going to have to be much more explicit about this. In other words, if you want to use multiple criteria, and we, government, want you to use multiple criteria, you're going to have to do it more explicitly and to build it in to your cost effectiveness analysis. Hence, this is the other really interesting area, I think it's interesting, area that has evolved over the last few years. And it coincides, we heard about MCDA earlier, it coincides with a big international movement in favour of this thing called multi-criteria decision analysis. That is, well, it comes in different forms. But essentially, I'll paraphrase it, I would argue that the MCDA movement has been very worrying because it just sees cost effectiveness as one criterion. And actually, there's a whole bunch of other things that decision makers should take into consideration. If they change that view to say there's all kinds of benefits other than QALYs, then we could be absolutely on the same page. But because what MCDA completely leaves out are the constraints, particularly budget constraints. They don't consider that at all. And therefore, they don't consider opportunity costs at all. And therefore, I would argue MCDA, in the form it's been espoused by this group and others, I think has got a lot of danger. And the NICE process of trying to do something like this has also exposed that danger. So this came through an initiative called value-based pricing. The government, the last government, originated, the current government picked up in 2010. And there's a number of issues with it. But what was front and center with value-based pricing, basically, was the need for NICE NICE effectively, to expand its measure of benefit, in particular, by including burden, disease burden, as an additional criterion in determining the value of medical technologies, and also to extend its perspective by including something called wider social benefits, which is essentially, on the whole, productivity. Again, as we were discussing earlier this morning. So the government basically wanted NICE to go away and figure out how it can retain cost-effectiveness analysis, but broaden the benefit measure. So it's now effectively burden-adjusted QALYs, and that it includes wider social benefits, i.e. productivity, as part of that process. Now, there's a long, long story to this. The short story is that nothing happened. NICE came out with some proposals which went down very, very badly. They called it value-based assessment rather than value-based pricing. One of the things that it utterly rejected was the introduction of productivity into its deliberations. Indeed, they claimed it would be formally illegal for them to do so, because one of the problems with introducing productivity is there is an age gradient on net productivity. That is, if you extend life of a 35-year-old on average, they are on average net producers. They produce more than they consume. You extend the life by 1 year of a 10-year-old or an 85-year-old, on average, they're net consumers. They consume more than they produce. So by extending their life, you actually impose costs on the system, or on society, on the economy, by extending their life. And that becomes very transparent in a framework that looks at net productivity. So not surprisingly, NICE said, we're not going to touch that with a barge pole. Interestingly, as an aside, and I'm just keeping my eye on the time, the industry have been pushing for productivity to be included for years. As soon as this framework was put together, and they realized, actually, we produce all these cancer drugs, which are mainly for people who are net consumers rather than net producers. They changed their position entirely and started criticizing NICE for even thinking about having net productivity as part of their criteria for decisions. So, but they did come out with some proposals. Basically, they introduced a concept of burden. Basically, proportionate shortfall was the measure of burden. I'm not going to get too much into that. They basically argued that in certain situations, if there's a high burden disease, or if there's, mainly if there's a high burden disease, the threshold could go up to 50. So the committee would decide when the threshold would go up to 50. And what they utterly failed to consider, and this I think is at heart of the challenge with multiple criteria decision analysis, is as soon as you widen the benefit measure, you have to widen the measure of opportunity cost. So it's not, so no longer, if QALYs is the only thing you're interested in on the benefit side from the new technologies, it's all you need to be interested in on the opportunity cost side. That is, it's just QALYs that get foregone by patients when you have to take their services away to accommodate the cost of the new technology. But if you're bringing burden, say, into it, now you've got to be worried about the burden of the diseases that patients have who lose services when you accommodate the cost of the new investment. And similarly, for wider social benefits, productivity, there are opportunity costs in terms of productivity as well when you fund new technologies. And our threshold work looked at that, was able to look at that. So what this shows is, for burden of disease, this is absolute burden and wider social benefit. On average, when NICE makes a positive funding decision, then the disease, the treatment, the diseases relating to the treatments that are displaced are exhibited by about just over 2 QALYs worth of burden. All right, so there are burden associated with the diseases for which the treatments get displaced to accommodate the cost of new treatment. Similarly, when NICE makes a funding decision, there's about £12,000 worth of productivity, net productivity, that are displaced as a result of that. And in some situations, you can see for some of these treatments, NICE makes positive recommendations down here, for example, prostate cancer, kidney cancer. For wider social benefits, these are the net consumers, all right? So you actually end up with a negative, by extending life in this area, you're actually worsening productivity. So that was a really challenging thing for NICE to accept. I would argue this is, if we're going to use multi-criteria decision-making in any form, we have to think about the opportunity costs associated with those additional criteria. Conscious of time. Okay, this is a bit more involved. This is what we thought might be the answer. This is what we've been trying to push NICE to do. We're still doing it. I'm not particularly confident. And it's what we think would be a social perspective, societal perspective, MCDA. That is, that we present a balance sheet. It's an impact inventory, in a sense, to the committees at NICE, and they can make their decisions. So here, just an example. This is Lucentis, diabetic macular edema. Needn't worry too much about the details. But basically, the cost per QALY is about £25,000. There was 23,000 eligible patients. So what we could show, firstly, to the decision makers is, well, this drug doesn't have a mortality effect, therefore doesn't generate life year benefits. But because it costs the system £80 million more per year than current practice, it will sure as hell have opportunity costs in terms of deaths and life years for other patients in the system. And we can express that in terms of QALYs as well. So in net terms, at a cost per QALY of 25,000 and an estimated opportunity cost at the margin of £13,000 per QALY, as I showed you earlier, this would have a net detrimental effect on population health. However, well, the burden of diabetic macular edema is somewhat more than the average burden associated with the disease for which treatments are displaced. Perhaps more interestingly, though, we get productivity benefits of a net positive effect on productivity of about 85 million from Lucentis. And we only forego about 50 million. So there is a net productivity benefit here. So we've got a very stark trade-off. In funding this, we actually have a negative impact on population health, but there is a net effect on productivity, a net positive effect on productivity. So ultimately, from a multiple perspectives, multiple criteria viewpoint, the trade-offs are quite stark for the decision-making body. So they could just take, as they would currently do, a health and healthcare perspective, which would indicate, why would we fund this technology? It reduces population health by about 3,000 QALYs. But we could equally take a view which we're not interested in health at all. And this is the sort of naive cost-benefit analysis approach, not the CBA approach we were talking about earlier, but this is how it's been operationalised in some settings in the past. That is, we actually get a positive effect. It costs 80 million, we get 85.2 million pounds worth of net productivity gains. So basically, we have a reduction in net societal costs, if you like, of about 5 million. But that sort of societal perspective fails to take into consideration the fact that there's a budget constraint. So we could have a societal perspective which accounted for the opportunity costs in terms of health. So we've got a net loss of 3,000 QALYs. We've got a wider social benefits of 85 million. So in that context, we could say, all right, we're losing QALYs, but we're getting productivity. So as long as a society, our willingness to pay, if you like, our consumption value of a QALY is less than about £29,000, then we would fund that. That's the sort of trade-off. But even that's wrong because it fails to reflect the production opportunity costs associated with a fixed budget. So in reality, that loss of 3,000 QALYs has to be set alongside not the 85 million, but about 35 million once you allow for the opportunity costs and productivity. Now then, we would fund this technology if our consumption value of health, our willingness to pay for health, was less than about £12,000. That is the type of framework we would need to move to, we would argue, if we bring in multiple perspectives and multiple criteria. Right, I'm conscious of time. I'm just two slides left. Firstly, both of these relate to sort of reflections outside the UK. At one level, I recognise this is quite a parochial view, but I think we have sort of tested cost-effectiveness analysis in a sense almost to its limit. Found it wanting, but there are approaches and ways forward. The two areas I'm going to talk about sort of internationally is firstly the work Doug and myself and colleagues have been doing on the panel. It was a really great honour to be asked to be part of this. I'm the only token European on that panel, and I've been a pain in the butt for the last 3 years with them. But I think some of the insights in the UK were very important in discussing the concept of the societal threshold, which was so important in that first panel book, the Gold et al. Book. This time, well, we'd have to wait and see when it comes out in October, what it says. And it's still important, societal perspective, but how it's operationalised, I think, has a lot more detail in it. In other words, everybody wants societal perspective. The question is, how do you achieve it when you reflect different sectors with different constraints and different objectives, different benefit measures? So, I think the discussions on that group have been really good in just seeing how the US viewpoint of how cost effectiveness is used or isn't used aligns with how it has been used, with to a greater or lesser extent some successes and some failures in the UK. And the second sort of international perspective is around the International Decision Support Initiative, or so-called IDSI, which Elliot mentioned earlier. This is a Gates-funded initiative led by NICE International in the UK and HITAP in Thailand. We were one of the academic partners for the first tranche of funding, which ended last year. And this also, I think, has been affected, I hesitate to say benefited from, the experiences we've had in the UK. I think it's been certainly impacted by those experiences. A couple of key elements of work there. Firstly is this concept of the reference case comes up. And the IDSI developed a reference case for Gates-funded, we hope for more generally, for work being undertaken in low and middle income countries. And if you look at it, you can summarise it on a page. It's not all the detailed stuff in the Gold Book or the updated book or in the NICE guidelines. It's it's a set of principles rather than detailed methods. And that, we can talk about that later perhaps, but that I think reflects just the complexities of doing cost-effectiveness analysis in a range of different decision-making contexts with all the constraints about capacity and expertise that we talked about earlier. The other thing that has been done in this work, and I think Elliot talked about it earlier, is trying to estimate cost-effectiveness thresholds based on opportunity costs for low and middle-income countries. And now we've got a couple of papers in draft form that have tried to do that based on available data. It's even more imprecise than the UK estimate, but it's work in progress. Thank you.